we'll be talking about rural populations and infectious disease transmission implications for COVID-19. We appreciate you being here with so much going on in the world today. We look forward to this very timely discussion. A few notes that we will be recording this webinar. The webinar will be made available shortly afterwards via email to everybody who registered for this event, along with the slides. And we will be taking questions throughout the event. So if you have questions, please submit them to the host, which is me, and we will do our best to get to all of the questions before the end of the event. With that, I'd like to turn it over to Dr. Jermaine Lewis, Dean of the College of Health and Human Services, who will be our moderator for this event.
Thank you, Michelle, and welcome. And I'd like to thank everyone for participating today in what will be a really important webinar focusing on COVID-19 infections amongst rural populations. There's been a lot on the news about COVID-19 spread, transmission, treatment, and the whole bit. And frequently, the news portrays large cities being affected in densely populated areas. So I'm really excited about the webinar today and our panelists who will be speaking about the implications of COVID-19 for our rural populations. They're a part of this pandemic as well. I'd like to introduce the panelists, and you're in for a real treat. We have renowned experts in their field who are giving their time today to talk about the implications of COVID-19 in rural populations. Our first panelist is Dr. Kara Frankenfeld, who is an associate professor in the Department of Global and Community Health here at George Mason University. Kara is joined by Katerina Scaglio, who is the Paulsley Professor in the make sure I'm getting this right, Uyghurs Department of Electrical and Computer Engineering at Kansas State University. She's also joined by Shirini Venkatramanan, who is a research scientist at the Biocomplexity Institute located at the University of Virginia, so our neighbor to the south a bit here at Mason. And I'm Jermaine Lewis, the moderator for this panel, this webinar. Just a few comments about the webinar today. Our three panelists are going to share slides with you and speak in their areas of expertise for about 25 minutes. Following their comments and remarks, we'll be opening up the session to questions from the audience. Dr. Frankenfeld is going to give an overview on rural populations and factors that influence health in those populations more broadly. This will be followed by information about COVID-19 for rural Kansas. This will contain information about prevalence and preventive behavior effectiveness that Dr. Scaglio will be addressing. And lastly, Dr. Venkatramanan will discuss epidemiological modeling of COVID-19 and specific applications to Virginia. So for those of you who reside in Virginia and who are joining us today, this content will be tailored to Virginia. Our moderator, Michelle, will ask the kickoff question of our panelists to get us warmed up and started. And if you're in the audience and you have a question, please submit the question to the host online, and your question will be raised to the panelists for further discussion. Without further ado, I will ask Dr. Frankenfeld to please continue with the program and begin. Thank you.
Hi, everyone. Thank you for being here today. Geographic health disparities are common for many diseases and deaths in the population, and we might expect in the coming months, as COVID-19 continues its spread, we'll see geographic differences in COVID-19 infections and deaths in the United States. And one of the ways that we see disparities and we can consider geographic areas is based on the classification of rural and urban. And my goal in the next few minutes is to provide some background information about demographic and economic aspects of urban versus rural areas that may contribute to differential impacts of COVID-19. I'm going to be talking about rural and urban in the context of counties because this is often the level at which we can obtain health and population-related data. And in general, rural-urban classifications are based on things like population densities, land cover, presence of airports, and distance to metropolitan areas. The U.S. Census actually starts with defining what is urban and urban clusters, so our metropolitan areas, and then classifying what remains as rural or non-metropolitan. And so I've just included two maps here for general reference of counties that are considered either mostly rural or completely rural within the United States. And you can see that they include areas throughout the U.S., but there's some clustering of the completely rural areas in the plains and the western northern part of the United States. Next slide, please. Another way that you could think about this so that you can put those two groups together is to look at what are the areas that are considered mostly urban, and they're in purple here. And then the areas in white are the combined areas on the previous two maps that are either mostly rural or completely rural. And a really important feature of these areas is the amount of population versus land area. So 19% of the population lives in rural areas, but rural areas account for 97% of the land area in the United States. So this drives area characteristics like demography and economics and behavior, which can be important factors in infectious disease transmission. Next slide. So in terms of demography, I've just highlighted a few population and housing characteristics across rural and urban counties. And what's being displayed in this graph is the average percent for the characteristic in mostly urban, are blue bars, versus mostly rural or completely rural counties in the red bars. So some characteristics that we can see here for rural areas on average, there's a higher percentage of individuals who live in poverty, a higher percentage of individuals with less than a high school education, a higher percentage of individuals older than age 65 years, more individuals with disabilities, and more mobile home units and crowded housing. There are, however, lower single-parent households with children and lower multi-unit housing. And I want to note here that the unemployment percentage in this graph is relatively low and not different across the rural and urban areas, but this data is from 2018. And county level estimates for the past few months are not yet available in terms of unemployment, but we do know that current unemployment is actually around 15%, and state level data indicates that states that rely heavily on manufacturing, such as Michigan, and tourism and recreation, such as Nevada, have the highest rate of unemployment right now. Next slide. So an important consideration there is when those different characteristics intersect. And so this map illustrates where there are hospitals and not, and where there are ICU beds in hospitals versus not. So the gray parts of the map, there are actually no hospitals. The orange parts of the map, there's hospitals without ICU beds. And there's considerable overlap in these gray and orange areas, so no hospitals and hospitals without ICU beds, with the mostly rural and completely rural counties. And this is really important because we're seeing with COVID-19 that people are needing extended hospital care and ICU care specifically. And even when we see areas that have ICU beds, the rural areas have a higher number of individuals older than age 60 per available ICU bed. And so we don't yet know what impact that is going to have, but it is a concern that the availability of care for a more vulnerable population or older population will be less in rural areas. Next slide. So some of the economic characteristics of rural versus urban areas may also contribute to differential impacts of COVID-19. And so this graph illustrates the percentage of counties that fit various characteristics by mostly urban, again, in blue, and mostly rural or completely rural in red. And what you see here is that a higher percentage of rural counties are farming dependent, mining dependent, manufacturing dependent, and have more industry devoted to tourism. There's also a higher percentage of rural counties that have low education and persistent poverty. And we are seeing that particular economies or industries are placing people at a higher risk for COVID-19 because transmission and person-to-person contact is higher. So industries like recreation or manufacturing-dependent industries. Next slide. And recently this observation was made that even if we just look at rural counties, those counties that had a meatpacking plant had higher COVID-19 infection rates. I do want to stress that this particular analysis was preliminary and descriptive, and we don't know if there are differences in testing across the areas, but it does raise a flag about the importance of employment and specific industries for COVID-19. Next slide. So overall, most of what's been observed and documented so far is from urban areas, but rural and urban areas have strengths and challenges that may set them up to experience COVID-19 in potentially different ways. And notably, rural areas tend to have older individuals and less healthcare. The economies of these areas also tend towards manufacturing and recreation, which are activities that may have more person-to-person contact. Industries like farming may have less. So not all rural or urban areas have the same economic foci, and it may be for rural areas that the lower population density, the fewer multi-unit housing structures might provide some protection from spread. However, what's not present in some of these structural factors that I presented is the differences in behavior and what actually happens with infectious disease transition. And what we have upcoming is an opportunity to hear from two experts in infectious disease modeling and what they're observing or predicting for Kansas and Virginia that have these very distinct urban and rural geographies. And with that, I'm going to hand it off to Dr. Scolio.
Thank you, Cara. Yes, I will follow the same concept that you have introduced with the specific case of Kansas. So this work has been done with Dr. Aram Vajdi, postdoctoral fellow in my group. So next slide. So Kansas has many states, more than 100 counties, and we can group them in 4 types in terms of impact of COVID-19. So we have urban counties, rural counties, college counties, and some special cases. And so we have circled some examples and reported the COVID incidents in those special counties that we want to analyze as example of those 4 types. So next slide. We can start with urban counties. So we have the example here of 2 counties. One is Wyandotte County, which is part of Kansas City. Kansas City is a large metropolitan area, and part of Kansas City is in Kansas in Missouri, and part is in this county. So in this county we had a global number of confirmed cases that reached 1,400. And so if we see the 2 graphs, we can see in the upper graph the confirmed total cases in time, starting from March and going to a few days ago. In the bottom graph, we can see the daily new cases. And so the end of the epidemic will be represented by a constant curve for the upper and a curve that goes to 0, no new cases, for the bottom. So we want to see that type of behavior, and at the moment we still have some cases. On the right, we see Shawnee County, which is the county where Topeka, the capital of Kansas, is located. Is less populated than Kansas City, and there we had 300 total cases, and we can see that these cases are still happening in the end of May. If we go to the next slide, we see Johnson County, which is a suburb of Kansas City. Very, very well-populated county, one of the most populated county in Kansas. And here we see also a number of not negligible number of cases, up to more than 800, and new cases also, if you look at the bottom graph, at the end of May, up to the middle May and to May. So we have been wondering what is the infection rate that can be estimated through the behavior of Johnson County new cases, and went to try to do a fitting of this data. So if we can go to the next slide, we can see that if we look at the confirmed cases, we can divide the time into 3 areas. The first, maybe considering the time of March, the month of March, where we can estimate a reproductive number, R, which is the average number of infections created by a single infected individual, which can be estimated around 3. We did this through an optimal fitting of the data that are these blue stars compared with the prediction of a model and SEIR model. Then in April instead, we estimated a reproductive number of 0.8, so a much smaller value below the threshold 1, so that was probably corresponding to the lockdown period. However, we saw a change before the lockdown was kind of changed into the reopening, because we could estimate an increased value of the reproductive number starting the end of April up to now, which we can estimate to 1.12, which is greater than 1. So the reopening is probably bringing this reproductive number to a higher value with some concerns. Okay, next slide. So here we see instead that we go to rural counties. So we are not talking anymore about cities, but rural counties. However, these are special rural counties when we have seen a lot of cases. And those cases are definitely related to some special conditions. We have on the left, Leavenworth County, where there is a large penitentiary. And in this county, we have more than 1,000 cases. And on the right, I reported Ford County, where a meatpacking plant is located. And as Cara was saying already, we had probably the greater number of cases with 1,700 cases. And still sparkling, if you go and look at the lower graph on the right, still adding new cases. I know that recently it's going down. However, it was really very relevant. So these are rural counties where we had a spreading, a non-negligible spreading. So if we go to the next slide, we go to some kind of intermediate case, the counties where the universities in Kansas are located, Riley County, where Kansas State is located. We have had 66 cases, and here we have 64 because we had 2 cases yesterday, new detected. And where University of Kansas is located, we have had 66 cases. So still not the environment that could spread the epidemic, such as in those other special cases, but because of the university was closed, but still the population is moving, going, and maybe in different places, some kind of incidence is still there. And then we go to the next slide to look at what happened in the majority of the rural counties. In the majority of the rural counties, we had no cases. For example, here, Jewell County, 4 cases. Neosho County, 2 cases, many with 0 cases. So the majority of the rural counties had no cases of COVID-19. So we go to the next slide. We can try to make sense of why this heterogeneous behavior, heterogeneous cases in the counties of Kansas, and we can obviously understand that on the side of the strength to be protected against the COVID-19, there are those low population density, large areas, no public transportation aspects that really help with containing. But there are the vulnerabilities that already Cara pointed out very clearly. And I want to stress the fact that it is the last point, the last bullet point in this list, a limited access to testing, virus testing. We don't know actually if those counties have no cases or those cases are going undetected, and also limited access to healthcare facilities, which is really kind of sad and worrisome somehow. So next slide. Still, in rural counties, we could see contacts. It's not that even though the population is less dense, people don't get at all together. Definitely, there are few contacts, but the ties among people are very strong. And so there are also few and smaller locations for essential shopping. So those locations are somehow driving the contacts. And the contact network has a structure that is influenced by these visited locations. When in 2012 we did a survey to understand the behavior of people, we saw that was very hard to convince people to change their routine. We asked precisely the question to people what they would do if they were asked to stay home, not visit any other because of a serious pandemic, and about 50% of them said that they would still at least visit one or two households outside their home because of these very strong ties. Next slide. And this was the example in Neosho County, the county where we had 2 or 3 cases of the contact network. So people have some contact in some location that are those points, those in the map. And those purple points are the people. Links represent contacts where transmission can happen. But this network exists in terms of meeting maybe 10 people, 5 people at the grocery store when they go shopping. If we go to the next slide. However, the data that we have shown, this is data, not simulation, is influenced by the behavioral responses. Some were imposed, some were recommended, some shops were closed, so imposing different behaviors. But we can divide it into main categories, social alertness and social distancing. Alertness can be the fact that an individual being susceptible learn about the disease and take some preventive measures. So the infection rate for that individual becomes smaller. So that is the first social alertness. The social distance instead consists in changing the contact network for the individual, so reducing some of the links. Next slide. So this is my final slide. What we learned from the previous survey campaign and from analyzing the current data for COVID is that the compliance is definitely an issue in rural counties. Not necessarily people will follow what CDC will tell them to do. However, we believe that, and this is a conjecture, that with short contacts such those happening in shopping location, COVID can be under control, but is not under control in those special cases. In those crowded working places, maybe the contacts are longer and they can transmit. Obviously, the adoption of behavioral responses comes with the reduction in social relationships that can be very expensive in terms of emotional and mental health costs for people in rural regions. And at the moment, however, in the majority of those counties in Kansas, COVID-19 has been contained in a pretty good way. So I will pass the microphone to Srini now.
Thank you, Catherine. I'll continue from that. Thanks for the opportunity to present at this webinar. And I'll continue from this topic of rural and urban. I'll present something around what we're seeing nationally and focus on some of the efforts that we're doing for COVID-19 modeling in collaboration with VDH. If you go to the next slide. And I'm presenting in some sense like a large body of work by a group of researchers at Biocomplexity Institute at the University of Virginia. And we use big data and simulations, a lot of models that like what Katrina was talking about, building these contact networks and understanding social patterns, and to understand generally massively interactive systems. And we've also provided a lot of these epidemic and pandemic response and support for influenza, Ebola, and currently we're providing COVID-19 support for both the state of Virginia and also the Department of Defense. And I come from a group called the Network System Science and Advanced Computing. So we specialize in looking at these network representations of societal systems and use high performance computing to understand what's happening when something like an epidemic spreads through it. Next slide. Yeah, and so this is something that I think we've been tracking for quite some time. And I think like most of this is in the news everywhere. Like we've reached close to 100,000 cases and 100,000 deaths, sorry, and close to 2 million confirmed cases. And we've been compiling these like county level data for like confirmed cases, deaths, and recovered, and also like global data set wherever we can in this dashboard. And one thing that we see is if you go to the dashboard, you will see an interactive version of it where you can flip between counts and per 100K, and you can see that there's a very clear different pattern that emerges as you see this per 100K, because like as you look at counties that are impacted, there are more rural counties that are starting to show up, and especially if you look at something like a time lapse of which counties got cases, you're starting to see a story emerging. And next slide. So yeah, the story, and this is also some quotes from recent articles from over the past 2-3 weeks, and you can see these are somewhat clickbaity, but also there's a lot of truth to it, because they're basically saying that the COVID-19 is when the general collective consciousness, I mean, of the people is like we have already gone through it for 3 months, and so people are considering reopening the community and all of that. COVID-19 is just reaching rural America, and that we are seeing that in a lot of data sets across counties. And I think Kara and Katrina both highlighted all of these issues when it comes to managing an epidemic inside rural counties, because like you have a different, more elderly population, more underlying health conditions, and the healthcare system is likely to be stressed. And it's really challenging to do things like track and trace, which are one of the best ways to control it if you have people much more spread out, and it takes time for you to trace your contacts. And as Katrina mentioned, like they're going to be coming to the same Walmart, same grocery store. So the contact networks that we usually look at in like urban or like even college towns, they're very different when you look at a very sprawling county. And again, like things like meatpacking plants or prisons, they are they create these grounds for like infections to start, but then people take it back to the community because a lot of them work there, and so there is a very tight hub and spokes kind of interaction within a county, which once it takes off, you see these giant outbreaks that take off. Can we go to the next slide? Yeah, and so these are some of the scattering of analysis. Some of this I think Kara mentioned at the bottom, like, and these some of the zoomed in versions you can clearly see like these dots actually represent the meatpacking plants. I think some of these are in Iowa and Nebraska and Kansas, and the heat map is completely independent data, which is just infection rate at counties. And you do see some spatial pattern, and there is more to be revealed in terms of like why some of the rural counties are seeing these big outbreaks. And this is a really nice paper that came out almost like just a week ago by Peter Cohen from UMD, and UMCP, sorry. He's looked at how like these different prisons or meat and poultry processing or nursing homes have caused these giant spikes in mostly rural counties. And we are also seeing things like, if you just look at number of new cases coming daily, if you look at it nationally, we are seeing almost like a flatlining and slowly going down. And this was seen, if you look at something that happened in Italy or South Korea, South Korea had a very sharp epidemic curve, like the kind of curve that Katrina was showing, where like you had a huge outbreak, and then through strong testing and tracing program, they were able to bring it down. Whereas US is having a much slower trajectory downwards, and that's the story of these mixed outbreaks. While like the hubs, hotspots like New York City have gone down tremendously in terms of like hospitalization and deaths over the past month, we are seeing these new hotspots emerging. And like this statistics from that paper suggests like just about 2% of new cases were from rural counties in late March. Now they contribute to like 8% of the new cases. And this is without correcting for population bias. So you can see that like if you look at it per 100K, they're experiencing larger and larger outbreaks. And on the top left also, this is a quick thing that we tested based on like when the first case in the New York Times data set, like when did the first case get reported for each county, and then looked at from census, what is the population percentage that is rural, which is just based on 2010 census. And you can clearly see all the light colored ones are urban populations, and they're all, most of them have their onset before mid-March. Whereas a lot of the rural counties, which are like less than 100,000 population, are yet, just seeing their first cases. And so it's still an outbreak that's evolving. So it requires us to keep pace with it. And while people think that some of this could be because of testing bias, it is still very possible. We didn't observe a lot of testing bias at the state level. But again, from experience, we can see that like once a state starts testing, they tested their hotspots, and so the test distribution within states can also be very heterogeneous. So not all the tests get population proportionally distributed. Given there is limitation of tests, they'll focus on where the outbreak is. And so even though states seem to be doing similar in terms of per capita tests, the rural areas may not get tested that much. So that's a combination of the disease kind of radiating from urban to rural, but also testing just following it. And it makes it very tough to understand how the radiation happens. So if you go to the next slide. So we have been working with VDH closely over the past couple of months, I think. The time frame has been very warped through this pandemic, but we've been closely working with them, providing these weekly updates using a model. And in addition to this weekly update, they've also been compiling something like an executive summary based on some of our analytics that allows them to make messaging better, like how their social distancing efforts have helped, and how different metrics like days from onset to diagnosis have dropped, because that's a good indicator of you're testing more people, or like you're catching people earlier than what they would normally do. And those are good metrics to track. So we've been helping them with some of these analysis, but we have also been running a county level model using commuter data set. And if you go to the website that's linked there, you can see the COVID-19 model explorer, where you can look at different scenarios that we're projecting based on different likelihoods of rebounds. Like earlier, we were looking at different likelihoods of impact of the social distancing, like from March to May 15th, when we were socially distancing, we were trying to look at what if it reduced mobility by 30% versus 50%. Now that like I think most counties of Virginia are in the phase 1, so we are looking at different scenarios based on how much the mobility rebounds, and also what impact this better detection or like better testing could bring in. So if you go to the next slide, I can quickly go through this. This is the kind of modeling framework that we're talking about, where this is mainly a model at a county level, because for the early kind of questions of when will it reach a different county, or how the interactions between counties spatially and like in terms of commuting patterns, how does it drive the outbreak? So we built a model we have a model which we have used for influenza at the national level, so which we repurposed for Virginia. And this is an extension of an SEIR model, where we also added asymptomatic infections and appropriately set the parameters based on what's known for COVID-19, the slightly longer incubation period and so on. And we have been making these scenario-based projections. So it's not technically a forecast, but it's a way to allow people to plan based on different projected scenarios, and also guide the messaging, which says like if we were to do this, we might end up here rather than there. And that allows people to make decisions both at the individual level and public policy level. So if you go to the next slide. Yeah, these are some more additional analytics, but like we've also been looking at like hospital surges, like just since we are producing these infection counts at county level, we can aggregate them at like these hospital alert system VHASS regions, and then we can look at like based on estimates of capacity that they say for the hospitals there, when will we exceed the hospital bed capacity if we assume 80% versus like a 20% additional surge, and across the different scenarios. And like Katrina had mentioned, like we've also been doing these effective reproduction number analysis across different subregions. So we know if some regions are experiencing more than others. So like what we're seeing is like northern and central, where they're more urban, you're starting to see something that's under control, like slightly less than 1, but it's still teetering around 1, so it can anytime like bounce back if significant rebounds happen. And we are also seeing some interesting patterns when we look at mobility data sets that have become very pervasive in this pandemic, like sources like Cubic and Google have been providing data sets online. And like the bottom left is an analysis based on a really nice portal set up by like UMD, which have been compiling a lot of metrics to look at social distancing index by county. And what you see there is like the leftmost subplot is like the urban county. So you see a lower social distancing index is that they're operating like normal, and a very high social distancing index means they're basically staying at home. 100 means they're completely staying at home. And so you can see a large spike that happens right around March 15th when like school closures and all of these are mainly VA counties Virginia counties that I'm showing. So you see a huge spike up to almost like 80 for some of the counties, and slowly it starts waning down. And this highlights the challenges of behavioral modifications that they may not sustain. And now we are expecting this to continue to return to baseline. But the interesting pattern is like on the rightmost of those 3 plots, that's the rural counties. Some of it is because of data bias, but you can clearly see the scales are the same. Like it's still the same y-axis, but the rural counties, it might be because the ability to social distance is less, or it could be that the adherence is less, or even the coverage is less. So it's a combination of those effects, but you can see these are indicative of we're dealing with 2 different kind of interactions, even within a state. And the same thing happens when we look at it at how many people are returning to workplaces, and there's a clear difference in terms of regions. So if we go to the next slide. Yeah, and also we have been looking at this, like as I said, like since we're looking at hospital surges, we have another dashboard that primarily serves like VDH folks, but also like we are expanding this to the national scale, where we are combining data from our simulations under these different scenarios and hospital beds and ICU beds availability at HRR hospital referral regions. And this is again like from I think the Hospital Association, American Hospital Association data, and using that to say like what would be the expected surge. This is not exactly like current bed capacity, but more of estimated based on what they reported during their hospital census. And it gives a good idea of like this disparity that if you look at it in the national picture, there are counties which may not have too many cases, but just because of their healthcare system, they might get quickly overwhelmed. So it requires a lot of planning. So if you go to the last slide. Yeah, and again, like this is a quick thing that we are starting to do at the end, which is now that questions are switching from like just projections for different counties, there is active efforts for controlling the pandemic by doing active test and tracing. And so we are building these more detailed agent-based models, which are connecting people through their activity patterns and like people going to different locations for work. And this allows us to actually do things like test and trace through social contact networks. And also it explicitly captures the urban-rural differences because you'll have fewer activity locations and then people spread out much more. The households are much more spread out. So it allows you to capture that diversity within the state's population. And it also allows you to quantify the effect of staying at home better because the households are actually units. If everyone stays at home, the edges outside the household will be cut out. Whereas in a much more mixing model, it's tough to reduce those interactions in a very surgical way. So in conclusion, I think, yeah, go to the next slide. Yeah, so this is just in closing, like I think the implications for modeling and response are, there are a lot of them when we start accounting for these heterogeneities. First, like since there is already a heterogeneity that's induced by age-specific severity for this disease and underlying health conditions, this is still being explored. We still don't know like what is the exact increase in risk if someone's having cardiovascular diseases and so on. So each of these, it's coming through clinical data, but integrating that into the simulation will help us map it with like what we know about prevalence in the county. So if you have US data, which is prevalence of different diseases in the county, how does that affect the disease burden that we will see? And this is complicated by the testing bias that I talked about and other biases that come into just the surveillance data collection. And this is kind of a technical point, but I think this bears to be spoken about because, like, if you look at a model that's across spatial resolutions and across different outcomes, just making a model that explains all of that is very hard. And sometimes some of these are very tough to explain, given these are very localized outbreaks, which are happening in prisons and meatpacking plants. And so how do you build a model that forecasts without like trying to explain every single thing? It's something that keeps us awake at night. And again, like this has also response implications because like when you reopen a state, like we are currently entering phase 1, so you need to start thinking about inter-county commutes. So you can't just deal about a county separately. You have to somehow coordinate policies across states and counties because when university town opens, there might be people who are serving the university who are in the neighboring counties. So you need to look at these cascading impacts of this reopening decisions. They cannot be dealt with in individual form. And similarly, like the economic impact might be much higher in rural areas, depending upon the employment, the sector that they sectors that they're working on. And so, like I think, like it is an ongoing challenge, and we should keep in mind all these disparities when we're planning logistics, right from testing or hospital management and all of that. So I think that's where we stand right now, and we just hope that like we figure it out before it gets too bad. And so I'll end with that and hand it over to the moderators.
Thank you so much for that session. We do have some questions coming in from the audience, some specific questions for each presenter. We'll start with some general questions for each panelist. The first is, the COVID cases in rural areas appear to be very heterogeneous. What are the main factors driving these differences? And Katerina, perhaps we'll start with you.
Okay, thank you. If you can unmute and mute me, I appreciate a lot. So I think that we can always say that these the spreading is driven by the contact network. So we see that there is a contact network also in rural counties, and that there are activities that are still going on in all these counties, but the conjecture is that some of the counties have activities like the meatpacking plants where the spreading is facilitated, while other activities, for example, where you have a large agricultural industry or other type of industry where instead the virus does not spread. Obviously, in those places, we still have contacts. I think I showed this contact network for Neosho County. People go to Walmart, but probably that type of contact is short, is very not maybe strong and close enough to spread the disease. I think we could verify this kind of conjecture if we start getting data from contact tracing apps and see the importance of the number of contacts and the duration. So it seems that it's more the quality of contacts, long with a lot of interaction, rather than very quick spreading contact.
Srini, did you want to take that question about what you see as the heterogeneous factors driving the rural area cases?
Sure. Yeah, I would echo this contact network and activity patterns being different in rural and urban is a very important factor because it's going to spread very differently than in an urban context. And the other factor that I think becomes relevant is like the data sparsity issue, which is like when you look at all these apps that we are looking at, there's much more prevalence, or like you can get a better sense of what's happening there. Much even when you look at testing and all of that, it's much earlier that we detect that there's something going on, that you're able to respond. So it's not like a weather system where you observe, but it's more like a control system where you interact with it, like both policymakers and also individuals. So when something happens in a much more urbanized setting, like you get a lot of signals, both the policymakers and individuals, that you can respond to it, and people react to it much faster. And while the rate of spread is also faster, so it's a trade-off. But I think like in rural setting, it might go unseen for some time, and then you'll see these smaller outbreaks that show up, but you might see a collective burden that increases, and it doesn't get tracked that much. And that's the bigger worry. And especially with the underlying health conditions, a lot of COVID deaths, even in urban centers, what you're seeing is they're getting attributed to COVID because the testing has not reached them, and they die in a cleaning out. They're already suffering from another health condition, and then so they're either, depending upon the hospital system, they get either called probable COVID death or they get attributed for different reasons. So just knowing the actual burden as it unfolds becomes very tough. So I think that's one thing that we should be looking at. That doesn't exactly accelerate the cases, but lets it grow undetected for longer.
Kara, was there anything that you wanted to add to this question?
I think I would just emphasize some of the things that have already been highlighted, is that rural areas are very heterogeneous in themselves in terms of features that they have. And so areas that are more touristy or recreational, some of our rural areas are seeing a different sort of contact network that's coming in because people are coming in from the outside to go to those areas during this time. And so there's some things that are just features of areas that are unique and much more unique in a dispersive way across rural areas. I would also add that each state is handling things in different ways. And so some states have different counties that are at different levels of openness right now, and it's based on what's happening in those counties. And so we'll also see some differentials that happen across what state decisions are made about reopening as we move forward.
Thank you for that. Our second question, and we'll start with Srini for this one. Are the recommended mitigation strategies working also in rural regions as they are, or should they be tailored to specific environments?
So that's a really good question. At least when we're looking at these metrics, some of the recommended metrics of social distancing, as I talked about, it seems like at least the level of social distancing that we are seeing based on these different app data seems to be much lower. And part of the reason why we are not able to see its impact on the disease transmission is also because they're starting to see cases only recently. And so the decision of like reopening states, why that's dominated the national conversation, and even across states, it's becoming, and that's something that we have to be mindful of. And when we talk about like whether the mitigation measures are working in general, yes, because in the context of Virginia, like days of onset to diagnosis have come down, and generally we have kind of paused the growth by reducing the growth rate and all of that. But when we focus specifically on rural regions, since they're just starting to see their early cases, it's still too early to tell. And I think the best way is to stay the course and try to improve our ability to detect rather than respond much later. So that's, I think, the key to responding to this.
Thank you for that. Kara, did you have any comments you wanted to add?
I think in coming back to this idea that the features and structures of rural areas are pretty heterogeneous, I think there are going to need to be some mitigation strategies that are tailored to particular areas, because some things may not seem relevant. And one of the things we know about people's behavior when they get information that's dissonant from what they're actually experiencing, they tend to tune out information, and then they get frustrated, and then they decide to do whatever they want to do. And so we need to be, I think there's a need to be cautious and to be tailored for areas to what makes sense for those areas based on the economies and the industries and the types of activities that people are most likely to engage in.
Thanks for that commentary. We can turn now to the specific questions. We have a few specific questions for Katerina. We'll start there. In Kansas City and Topeka, are the counts from positive tests or tests plus antibody tests?
I think they were for positive tests. They were detected virus.
Okay. And there was a question about your specific data point that 49% of those asked would still visit people in a pandemic. Was there a survey conducted? How did you gather that data point?
Yes, that is a good question. We surveyed the 500 households in Chanute County. In Chanute, which is in Elsho County, is a city. We mailed some of those questionnaires, but also we went to 2 events in the city and distributed these questionnaires. So we got answers from people. And from those, we got these 50% people will keep visiting at least 1 or 2 other households, even though they were asked to stay home.
Excellent.
And so that was many years ago when it was just very hypothetical, but then they were asked really. And so we thought that was really interesting. And I don't know if that changed what is their feeling, but I don't think so. I think that there are some strong relationships, strong ties that are maintained.
Now some specific questions for Srini. One you did touch on a bit, but the person asked if you could speak a bit about whether more rural areas were really locked down in the same way that the cities seem to be, and if you were using any kind of cell phone data to track that movement.
So so the slide that I talked about, that mainly looked at like 2 different sources. One is from Google Community Mobility, which is actually, both of these are smartphone-based data sets. One is much more aggregated by UMD by combining it with transportation and other data sets. And they come up with these metrics like percentage of people who are staying at home, and then number of inter-county trips, and number of miles traveled from home. And they combine all of this to come up with something like a social distancing index. And part of it is like, again, as I mentioned, it's tough to disentangle how much of that is just because of data sparsity, whether like do enough people use those phones and that particular app in those communities. The other thing is also what social distancing means when in an urban community is very different from what it means when we are in rural settings. Like if they use a threshold of distance that is used to decide like whether they're staying at home or they're traveling, that completely changes when you go from one county to the other, and it becomes tougher to decide like when does an interaction form. Like as Katrina mentioned, interactions are responsible for infectious disease transmissions. There's increasing evidence that indoor tightly crowded environments are increasingly seen as outbreak locations like choir practices and all of that. So whether these kind of events are happening is very tough to track. And what we look at is much more like community level mobility. But the caveat to that is like we are seeing that like based on locations, you can see there are much more likelihood of people congregating in very tight locations when they're far apart and they're just for community engagement. You have fewer opportunities. So if you have to engage with the community, you get to gather in a much more tighter spot, and those can cause outbreaks. So I think, but based on the data, we don't see that much social distancing if you look at the indices. But like the data is also sparse in that setting. So I don't know if that answers the question.
We have another question related to Virginia and the level of coordination that has happened in the, in the DC, Maryland, Virginia area, and if you feel like that has helped potentially control the pandemic, and is there any early data supporting that it's working?
That's interesting. We have not actually looked at it across. I mean, we've been running a national model, but one thing that we have noticed is, at least in the Virginia area, like a lot of the early cases that we have seen have been driven by the Northern Virginia area. So, and there is a lot of movement between the DMV kind of complex, and therefore it's because of the workplace. I mean, stay at home and working from home, telework, and the school closures. I think that has had a significant impact, and we would feel it across that entire region. So although we draw these state boundaries, a lot of interstate commutes happen, especially in the Northeast. And so I think coordination generally helps. And there's a general question of, like, when you coordinate, it's not synchronized. So there's a difference between coordinating and synchronizing. And it's just a question of, like, knowing what's the disease state and trying to personalize the, as Kara was mentioning, like looking at different communities and seeing what works best and trying to coordinate it at both, like, state level resolution, but also like among the counties. So, yeah.
And a follow-up question for you regarding that: why were you using national models and not MSAs from census data?
So, no, national model, I meant like county models, which are at national scale. So, like, the model's resolution is still at county levels, but it's a model that's run for the entire nation using the commuter and airline data sets that connect all these counties. So that allows us to look at across states. Whereas for Virginia, since we were working closely with VDH, we could personalize this model much more for the Virginia setting, and we were able to analyze it much more detailed. So that's what I meant by the national model.
Great, thank you. A question for all the panelists. What work is being done to disaggregate case counts from jails in larger county counts? And we'll start with Katerina for that.
So you are asking which work has been done to disaggregate the cases happening, for example, in penitentiary with the rest of the population in some county?
That's how I am interpreting the audience member's question.
Yes, what we had was data we collected, the data that is available at the county level. So what we think is that includes the penitentiary data, but it's not necessarily everything. But we think that is the majority, but we cannot, personally, I cannot say exactly which percentage is to be referred to that specific and which part is instead general. We know that, for example, in the case of the meatpacking plants, people were getting infected in the workplace, but they were bringing the infections in the community. So overall, there was an effect of multiple type of contacts for the spreading. For the jail, I think that should be more contained because of the movement limitation of the people inside the jail, but there can be always visitors or workers that can spread. But I don't have any definite data on that.
Thank you. Srini or Kara, did you have any additional comments on that question?
I mean, I guess I would say I don't know that there's any concerted effort being made to disaggregate those particular counts. There was a recent MMWR from the CDC that came out that was looking at COVID-19 in correctional and detention facilities, where they specifically queried some of the correctional facilities. And so I think there's an opportunity to look at some of the data that's coming out of the CDC to see where they're seeing cases. But in terms of disaggregating from, say, county level counts, I don't know that there's necessarily a concerted effort at this point to separate those out.
Yeah, I think like it's mostly likely that it's very tough to disentangle, because some of these cases happen in the community, but they work in the prison. And so it requires detailed like epidemiological investigations to figure out whether it's part of the super spreading event or these are like secondary infections that happen in the community after that. And so in case of VDH, that is like if you look at the public dashboard, they already have these outbreaks, which is separately called out, which looks at like nursing homes, correctional facilities, and then I think meatpacking plants are also part of it now. So they're looking at these different outbreaks that they're looking at by county. They're just reporting counts. And part of it is also like once you go down to very few counts, then it kind of conflicts with the privacy aspect of it. So you would like to kind of respect that while trying to make it epidemiologically relevant. And the other thing that I've looked at is I think NY Times in their public dashboard or like their updated coronavirus in the US kind of page, they have a table which has all the outbreaks, the large outbreaks that have been associated with these facilities. So they have a big table which just says like total counts in different correctional facilities or plants and so on. It's some kind of an effort, and again like concerted effort has been mostly like crowdsourced effort now, and it becomes tougher for us to keep that updated, and we are relying on citizen scientists and citizen journalists to kind of keep that updated, which is part of the difficulty that we face.
Terrific. Thank you for that. And with that, I think we are out of time for additional questions. Thank you, everyone, for joining us. It sounds like there are a lot of very detailed questions about some of the data, and I would encourage folks who still have remaining data questions to reach out to our panelists for more information.